morning, ladies and gentlemen. So thank you very much to be with us this morning to this symposium where we are going to speak about implementing the third pillar of the WHO NTB strategy at country level and hear about the lessons learned from Pathfinder Countries. So it's my pleasure to be here with Professor Maurizio Barreto from Fiocruz and the University of Salvador de Bahia in Brazil. And I'm Christian Lienhardt. I'm working at the World Health Organization Global TB program in Geneva. So it's a very short introduction. The third pillar of the NTB strategy is mainly focusing on research. So the global NTB strategy has goals of ending tuberculosis by the end of 2030, in line with the Sustainable Development Goals, and is built on three pillars. One is about patients' care, centered care. The second one is about looking at the larger environment of social determinants of care, universal health care coverage, and universal health access. And the third is focusing on research. The third pillar is focusing on research both at international as well as at national level. So today we are really going to look mainly at what happens at the national level and concerning the support and the promotion of research at the country level. So with that, we start with the first presenter, who is Dr. Nebiat Gebrselassie from Geneva, Switzerland. She's working at WHO. Nebiat has had a PhD in immunology from Cornell University and been working with the Karolinska Institute in Stockholm. And she's been working at the World Health Organization Global TB program for almost a year now. And she's been really the working bee on establishing what we call the Toolkit to promote research at country level. So Nebiat, if you could please come and take the floor. Sorry to the presentation of Nebiat.
Thank you very much for the introduction. So can everybody hear me okay? So I'll just be doing a brief introduction into what the Global TB program is doing to promote the research and innovation pillar of the NTB strategy.
We need to control the time, no? Because this is really not so bad.
So I hereby declare no conflict of interest. So as you're all aware, intensified research and innovation is the third pillar of the NTB strategy. And the Global TB program has developed a global action framework for TB research, which was launched a year ago exactly, I think, to promote research and innovation both at country level and global level. So like I mentioned, the Global Action Framework, one of the essential components of the Global Action Framework is promoting research at country level, a strategy to promote research at country level. And the way this was envisioned was to basically support and encourage high and medium TB burden countries to develop and implement a national TB research plan, which will help them identify, prioritize, and implement their research needs. And of course, in time to integrate the lessons learned from the research outcomes into practice and policy. So there's now a focus on country-level research because it's becoming more and more apparent that country-level research is essential to address country-specific gaps and programmatic needs. It's also has shown to be very useful in optimizing global knowledge towards local application in a more effective and efficient way. And also building research capacity is a sustainable way of creating a culture of learning with regard to the TB control program. So to assist high and medium TB burden countries develop a national TB research plan, the WHO Global TB program has launched a toolkit called Toolkit for Developing a National TB Research Plan this week. And this toolkit was developed by consultation with various stakeholders as well, but mainly by gathering lessons learned from what we're calling pathfinding or model countries. So these are countries that have successfully developed and implemented national TB research plans centered around TB control programs. And these include countries like Brazil, Ethiopia, South Africa, Vietnam, and Netherlands. So by gathering the lessons learned and experiences of these countries, we've developed a toolkit to assist other high and medium TB burden countries to also develop national TB research plans that assist the TB control program perform better. So this toolkit has basically three main components. The first part of the toolkit is centered around the terms of reference for establishing a network of TB research stakeholders that will be leading the process of national TB research plan development. The second toolkit is a situational assessment template for reviewing national TB control activities and research programs. And the last part of the toolkit is a set of strategies for identifying gaps based on the situational assessment, for identifying research questions, and for prioritizing these research questions in a systematic way, and also has recommendations for monitoring the implementation of the National TB Research Plan. So the first, I'm just going to briefly go over this three toolkits. So the first toolkit is on establishing a network of TB research stakeholders, but this network really should have the program at the center, and the members of the network should of course include researchers, but also other stakeholders such as civil society organizations, NGOs, funders, healthcare providers, the Ministry of Health, partners, policymakers, and other sectors as applicable in country context. And this network is really the driving force for the development of the National TB Research Plan. It can have many different roles, but it should at least have 4 essential roles: advocacy for TB research, knowledge sharing to be a platform for knowledge sharing, to identify TB research priorities, and to plan for capacity building, to develop a TB research capacity building plan at national level. The second tool is a self-assessment tool for reviewing national TB control activities and research programs. And it has 4 main components. It's a template for situational assessment that centers around knowing your TB epidemic, assessing the performance of the TB program, assessing the health system in the context of TB, and mapping the research resources that are available in country. And this situational assessment tool will serve as the basis for identifying the research priorities. The last part of the toolkit is a set of strategies for developing this national TB research plan. So it will assist the network or the country in conducting gap analysis based on the situational assessment tool I introduced in the previous slide, to identify research questions and to prioritize them systematically, and also has recommendations, like I mentioned, for different monitoring indicators that can be used to monitor the progress of the implementation of the National TB Research Plan. So when we look at the bigger picture, you establish a National TB Research Network, you develop this National TB Research Plans, but then this network is also expected to help develop a plan for sustainable capacity building for TB research, and to ensure appropriate funding by advocating for TB research, both at national and international level, and also to design applicable context-specific indicators for monitoring the implementation of the National TB Research Plan. So with that in mind, now we are currently working with countries that are interested in using this toolkit to develop national TB research plans or national TB research strategies to assist their TB control programs. So the countries in blue are the ones I showed you earlier. These were our pathfinding countries. And the countries in red are those that are interested in using this toolkit to develop national TB research strategies, and the ones that we are liaising with and working with currently. So if there are other country programs here who are interested in developing national TB research plans, we're also happy to work with you to assist you technically in this process. So with that, I would like to acknowledge all the individuals and the programs and the countries that have contributed to the development of the toolkit and funding from the Bill and Melinda Gates Foundation. Thank you.
Thank you very much. Does it work? Yes. Thank you very much, Nebiat. So I think that I propose due to time limits, that we go straight to the second presenter, and there will be time for quick Q&As at the end of the session. So I'm happy to welcome Dr. Abraham Assefa, who is the scientific director of the Armauer Hansen Research Institute in Ethiopia, and who has been conducting research on infectious disease, mainly TB and HIV, for many years now, and have supervised a substantial number of postgraduate students. I also thank very much Dr. Assefa to have come at the last minute to replace Dr. Lady Zafekadou, the head of the National TB Control Program, who was supposed to give the talk and had visa problem. So it's really last minute replacement, and it's really much appreciated. So Dr. Assefa, the floor is yours.
Thank you very much. And as you heard, Leilisa was not able to come, so the presentation is based on his slides, but modified with some input from myself. No conflict of interest. So the story I'm going to tell you is about the TB Research Advisory Committee, a committee that was established as a platform to assist the TB control program in Ethiopia to handle its challenges through evidence-based decisions. It is a network of researchers, academicians, and partners supporting the government program. And it started in 2001, following a workshop that was organized with funding from WHO TDR to look at the role of research in TB control in Ethiopia. At that time, Ethiopia had just 65 million people, and the case notification rates were still increasing because the coverage, health facility coverage with DOTS was just 32%. And there were a number of challenges, including improving performance of the microscopy facilities in the country. And so there was a lot of room for support from universities, academics, and other partners. The meeting was held in the Armauer Hansen Research Institute, which facilitated the coordination of this program. And if you look at the red circle there, you'd see that the program that was set for that particular gathering had at the end a session which said planning the next workshop. But those investigators who came to that particular meeting were very concerned about this, and they said, we discuss and then we plan other workshops. When do we do the actual work itself? So it was all agreed at that session that we needed a mechanism to continue between workshops to working on assisting the program. And that's how it was established. These gentlemen and ladies coined the term TB Research Advisory Committee. The initial discussion was to call it a coordinating committee, but this was not accepted because the coordination required additional responsibility that the platform wouldn't necessarily take upon itself. It established its own terms of reference, and the first thing it did was organize training, because the need for researchers and for research within the program meant that a lot of individuals had to be trained on research methodology. And it was an easy thing to do because the partners had all the potentials to facilitate this. And in the next years, beginning from 2001, as you see, up to 2011, a series of annual training sessions were held. The first was using the union's program, a 10-day workshop. But after that, the universities managed to bring together experts to continue giving training for program staff through selection by the program itself. And up to 2011, there were 224 trainees that were given the tools to do research. And the funding for it, as you can see, was initially through the research institutes, but later on with the DCTP support, Global Fund, TB CAP, and later on TB Care. The trainings that were given to individuals didn't necessarily materialize in immediate research use or research output. So the situation was revised, and with the active interest shown by USAID partners, and especially ISRA and Yared sitting there, the plan was shifted to focus on training through hands-on research. So the modification was to create a modular type of course with 3 blocks of protocol development, data analysis, and manuscript writing, all to be done within a year. And this was to be handled through team approach. So initially, the big regions were advised to create teams led by program people, either from the program itself or from the regional laboratory, together with the regional university and others who are interested in participating in these projects. So between 2012 and 2014, 13 teams were established, and the training was given to 52 participants with the collaboration of trainers. You can see here Evelyn Klinkenberg and Rita and others in the picture here. Unfortunately, it's not very visible. And this was through the support of KNCV, the Union, TB Care, and USAID, and the institutions in the universities and the program itself. This was supplemented by a grant scheme for those participants who had the ambition to do more research. They were given the opportunity also to go ahead and apply for grant from the program. And as you can see, the selection was very stringent, 108 letters of intent, ending up with only 5 grants, actually, because of the limitation in funding, of course. But you can see that there was high interest from program people to apply for these grants. Between 2012 and 14, 18 different projects were initiated, and many of them were completed. You can see that these were more operational in nature, like implementation of TB, symptom TB screening, factors contributing to variations in case notification, case finding, behavioral determinants, alternative diagnostics, and so on, because these were all selected through the participation of the program. And the findings of these investigations were presented at national and international conferences, and they were shared also through the regular reporting network of the government to the regional health bureaus and the Ministry of Health, but also publications. As you can see, both local and international publications. The first one was on public health action, the whole supplement of these publications, and then others as well followed in PLOS and other journals. So you can see that the quality of the work was high, as demonstrated by peer review success. So that was the training, hands-on training for research. The other activity of the platform of TRAC was organizing annual national conferences. And the conferences brought together program people, academicians, including students who would like to do research on tuberculosis. And it was a 3-day program. The first day always was listening to the reports of the national TB program and the regional TB programs. And if you see in the picture there, you see TB program managers of regions sitting and facing the public, answering to the challenge that they are facing and criticisms about their performance. And the next day, the researchers presented their findings in the year, and these were also criticized. And then on the third day, a consensus was reached on what to prioritize and how to go ahead with further research. And later on, fourth day became World TB Day, when the funding was more secure. These sessions were held close to the World TB Day every year, March 21 to 24. And on World TB Day, community engagement was, of course, an important component then. And through these annual conferences, the Ministry of Health could discuss directly with academicians and partners and consult them on program issues as well. So there were side meetings that were held during these sessions. One of these sessions was developing the roadmap, revising the research priorities based on these annual discussions and coming up with a long-term plan to guide the national TB research agenda and improve the TB performance there. Over the years, the meetings were held in different regions with the participation of universities organizing these sessions regularly. And now it is become an annual event, which is led by the Ministry of Health itself. And in the last 3 or 4 sessions, the State Minister of Health was in session full-time, all 3 days, discussing, listening to presentations, which meant that program people took these discussions very seriously and acted on the recommendations, which was also very encouraging for the researchers because it meant that their work made sense. And community engagement with announcement of the activities and also passing the message of the events meant that TB awareness was enhanced. Currently, the TB program takes the track activities as part of its annual activity and the plans for it, and then it is reviewed, and also findings are evaluated. It is part of the performance evaluation of the program, how track is handling activities. And Secretariat is at the Arbor Hansen Research Institute, which is part of the Ministry of Health, and the chairmanship of this platform rotates between regions. The functions are coordinating the TB research activities in the country in collaboration with the TB research, with the TB program. And these slides that you see on the left side are slides that were prepared by the TB program itself. And you can see that it's part of the system itself now and is well integrated, including with the future plans as the program head sees it. So the next activity of the track now is to revise the roadmap to suit with the current interest of expanding from operational research to a broader approach to research on TB in general to assist the programs. And the operational research activity would be expanded to include further modes of research, but there will also be capacity building and an advocacy and dissemination activity. There would be 3 platforms that track would be pursuing in the future to try to address the emerging challenges like drug resistance and maternal and child health concerns and so on. So we are very happy that track has managed to succeed in the last 15, 16 years. And this was successful only because of the strong partnership that could be leveraged, and particularly because of the financial and technical support that we have been enjoying from partners listed here. Some of them are not included. I apologize for that. Thank you very much.
Thank you very much, Dr. Assefa. So we had the experience shown to us from Ethiopia, and the way we have designed this symposium is really to try and collect as many different experience and expertise as possible so that you can have a wide landscape of what is being done at country level to support and to promote research. So the next speaker is Professor Franjo Kritsky from the University of Rio de Janeiro. Professor Kritsky has done a huge amount of things, and one of them is to be spearheading what has been the first network of TB researchers and program managers in Brazil, so-called the Rede, and he will tell us about this experience of setting up a network and developing and implementing a multi-spectrum national TB research agenda. So, Franjo, the floor is yours.
Thanks, Christian. Thanks for inviting me to come to this meeting. And good morning for everybody who'll be here. No conflict of interest as asked for. The outline is, I will briefly let you know the Rede TB Research Network in Brazil, called Rede, activities since 2001. It's quite similar in some way for Ethiopia, has been said. In the Brazilian response to NTB strategy in the last 2 years, a national TB research agenda, how we perform, we develop it, interaction between Rede and NTP more recently, in final remarks. We started 2001 after 2 big workshops were held in Rio de Janeiro city. We decided to create a national TB research network, Rede. We work with the nodes, so at least 2 researchers coordinate each node, vaccine, drugs, and operation research, clinical research, And those research has a responsibility to share information, speed up the process, how we identify partners in Brazil and elsewhere. And also we have now currently several sites in Brazil, in different regions, working different tasks, clinical research, operation research, or lab stuff. As I said, since 2001, Rede, we start to act as a coenzyme to build bridge between different stakeholders in Brazil. You can see in the red ones, Ministry of Health, Ministry of Science Technology, Ministry of Education, even civil society. And more recently, we are working with Ministry of Industry and Trade, and also Social Development is crucial. So it's a long time, it's 14 years old, 14 years time. So since the beginning, we were working through research platforms. So we identify researchers working in a fundamental translation arena, clinical research, operational research, or implementation research, and also health system research. But crucial, as been mentioned before, capacity building for research is crucial. So we started since the beginning with Brazilian government money, and afterwards NIH money to carry on a huge capacity building program with 2,000 people, 80% from the services, they were receive capacity building courses from the master into doctorate programs. We follow the Global Action Framework for TB research, has been published last year. So the question is how to incorporate Pillar 3 in countries where NTP, usually they don't pay attention to research. Just to remind you, research has been highlighted by WHO only in 2006 in the Stop TB Global Program. Before that, research was not important. And I'm impressed with Ethiopia because they start earlier. How to incorporate Pillar 3, Pillar 1 and 2 and 3 to work together. So we have a 5-year plan to establish National TB Research Network, develop a National TB Research Agenda. We plan to build and maintain capacity for TB research, develop a national funding mechanisms, and also how to integrate research community at a national level and with other countries. So we're lucky in some way. We have our network since 2001. And our National TB Research Agenda was developed last year. And now we have to follow now the points 3.5, 4 and 5. What the consensus achieved in the last 2 years in Brazil, we have to go beyond NTP. We have to rely and reinforce government advocacy, interact with politicians, because they pay the bill. NTP has indeed incorporated research in social protection as a high priority currently, so Pillar 2 and 3 is indeed inside in the NTP nowadays. In the intersectoral approach, we have to foster interaction with the Ministry of Education, Science Technology, Social Development, Justice, Labor, Trade, and Foreign Affairs. We think that promoting interaction Pillar 3, 2, and 1, through implementation science, we can induce policies change inside NTP. That I think is a key word to make a bridge between NTP and academia, at least in Brazil and I think in other countries also. So just briefly, we have a Ministry of Health, usually NTP running everything. So we have different levels of health care, also community level. Nowadays, the idea is to work as a package. So you took TB transmission, control, diagnosis, and treatment cascade. But we have to work with Ministry of Justice, Social Development to work, for example, in prisons or to enhance or maintain cash transfer programs. And also what's the impact of active case find, molecular tests, patient-centered care and social support. We have to evaluate what's going on, what's the mistakes have been done, how we can refine the process. So we know that the greatest challenge is how to take prove interventions, the published ones, and implement them in a real world. That's the key. Implementation research is particularly important in a supported scale-up and their integration in the health system. We are convinced that through implementation research, we can foster the interaction between NTP and academia. Again, bringing the research platform, as you can see, to incorporate Pillar 3 in the system, using all the package, as I mentioned before. Implementation research play a key role, in fact, in several, probably several countries. The other question is how to include fundamental translation clinical research in national TB plan. TB NTP guys, they don't know what does it mean, and no attention has been taken in Brazil, at least. So it's like the research platforms, they are orphan. So they are doing translation science, developing new drugs, new vaccines in those countries. They have no contact with NTP. So I'm just let you know a very recent experience in Brazil. We made agreement with NIH, try to cover this arena. It's a reported national projects. So we started last year. We have a common protocol, a project within Brazil and in India nowadays, also in South Africa. Is just establish a cohort of TB cases in close contacts, use a common protocol, central data management, and national biorepository. So clinical samples and data have been collected in a very nice way. And then in Brazil, we have 5 sites, 3 in Rio, 1 in Salvador Northeast, and 1 in North, Manaus. Funds has been given by NIH 50%, the Brazilian government 50%. So those samples and data then can be used for example, validate biomarkers or to evaluate, to carry out the epi studies, TB and diabetes, TB, mental health, etc. And also those sites can be suitable for clinical trials. So our dream is that, at least in Brazil, we would like to have all research platforms working together. That's our dream in Rede and also now in NTP also. So then we can incorporate very deep way Pillar 3. As I said, last year we developed a national TB research agenda. It was published this year in Brazilian article. We identify 73 research priorities from 7 research platforms. And now, last August, in our national workshop, using electronic survey, we refined those agenda, and we came up with the 21 priorities from 3 among each 7 research platforms. Just an example, research platform 4, EPI, Operation, Health System Research. These 3 projects will receive more votes. For example, to evaluate the effect of cash transfer programs and other social benefits, to evaluate the stigma, discrimination, prejudice of TB, to evaluate the impact of incorporation of new technologies in different healthcare level according to the distribution of social inequality on TB. Another example, research platform, social mobilization, the 3 research priorities with more votes, evaluate the impact of relationship between local leaders in health services, evaluate the impact of communication strategies used by civil society organizations, and also evaluate the impact of communication actions, advocacy, mobilization on the adherence of TB treatment. So the activities has been carried out this year. NTP allocated 2 focal points for research inside NTP. It's very new in Brazil. In our Rede, we create 2 new sites to incorporate people from NTP work with us closely. Pillar 2 and 3 indeed was incorporated in the National TB Plan. Will be released at the end of this year with the Pillar 1, 2, and 3 in the document. We are starting the creation of national CCAP led by NTP and Rede. We started interaction with the Minister of Education, focusing funding, additional funds to reinforce and maintain the capacity building for research, TB research. We start interaction with Conitec. In Brazil, it's like NICE in UK, so we have to rely on Conitec to have any new products to be incorporated in the health system. So the idea is how we can work together to speed up the process and properly incorporate new products for the unified health system. And also we decide to promote the production of recombinant PPD developed by Brazilian researchers. As we know, PPD is very, we don't have PPD in Brazil. Final remarks. So we realize that we as Rede and also NTP, when we are implementing new technologies, can be drugs, diagnostic, vaccines, or new interventions, or revising national guidelines, we should, if it's possible, when possible, use impact assessment framework that include evaluate effectiveness, equity, health system, scale up, and horizontal analysis combined with qualitative analysis and sustainability perspective. Thanks a lot.
Thank you very much, Afranio. It's fascinating to see how you have evolved from starting with operational research and really evolving to bring all the various aspects of research, and how now there is really, you are addressing in Brazil the full spectrum of research, from the most fundamental aspects to the most operational aspects. I think that's great. I think the audience has been increasing, which is very good. So what I propose now, the next three presentations are more related to looking at some specific aspects of looking at spatial data, and how looking at specific data can derive and influence the research agenda. So before that, I would like to know whether there is any burning question that you would like to address to one of the three speakers. No? Okay, so that means everything is clear. Very good, so we continue.
Okay, I'm now in charge to call the speakers. It's a pleasure to be here on the side of Chris to coordinate this symposium. And I would like to call Dr. Priya Sheet. Dr. Priya is a physician in pulmonary and critical care medicine at the University of California, San Francisco. And she's a consultant in the research TB elimination team at the Global TB program at WHO in Geneva.
Thank you. So today I'm going to talk a little bit, as Christian mentioned, about some of the concrete steps that countries can use in looking at their data and data sources in order to prioritize research within their national strategic plans and to implement Pillar 3 more concretely. So the title of the talk, as you see, is Methods in Country-Specific Research Prioritization. I have no conflict of interest. So this just shows some of the objectives I hope that you all get from the talk. First, I'd like to describe, as you all know, I think already, the importance of research prioritization at the local and the global level, to then describe some steps that we can take to develop a consensus methodology on how to prioritize research. And then I'd like to shift gears a little bit and talk about some of the preliminary results we have with collaborations from key Pathfinder countries. And you'll be hearing more deeply some of these results in the subsequent two talks. And finally, I hope I leave you with a little bit to think about on how to incorporate research within national strategic plans based on existing evidence. So I think you've all seen this slide many times in the last several years, but here it is again. And I think this is the reason why we'd like to prioritize research and think about research in its various capacities. So as you see, the current decline in TB incidence is really not going to be enough to achieve end TB goals by 2035. And so the questions that countries have is, how can we individually get there? How can our program achieve those goals? And so there are two potential strategies, theoretically, that could do this. One would be to optimize current tools, as you see kind of at the top of the slides, to then improve decrease in incidence. And then there's this hope for a new game-changing intervention, a diagnostic, a therapeutic, something that shifts the paradigm and gets us to 2035 goals. What's not clear is how countries can do that in their own contexts. So how can we get there? And I propose that it's through better understanding of local epidemics and better leveraging of local programmatic infrastructure in order to then provide some new and renewed interest in vulnerable populations, overlooked populations where TB burden is high and interventions might be better targeted, as well as then develop more innovative methods and tools to do that, and all through research. So what we propose as part of this work is to create what we call the TB Research Investment Case. And the overall aim of this project is to develop investment cases that inform operationalization of the NTB strategy based on local estimates of epidemiology, impact, cost effectiveness, and with a better sense of how existing or hypothetical interventions might impact specific settings. This diagram is just to briefly describe the approach, which, as Nebiat in the first presentation showed, is a stepwise kind of process. We started with the development, honestly, of a group of experts, advisors, to form a technical advisory group to assist in the development of a methodology for the research investment case and to develop a protocol that could be translated to some of these pathfinding countries, which I'll get to a little bit more in a moment. That moved into development of a situational analysis, agenda revision within each of these countries, and to conduct a data inventory, which is not particularly exciting, but very important to better understand local epidemics. The subsequent two kind of phases of the work are to then develop a model. It could be a conceptual model, it could be an epidemiologic model, an economic model, to assess the impact of potential interventions on a target population that has been identified by a locally derived situational assessment. And finally, the results, we hope, will prioritize research within these countries. So the countries that we chose actually are Brazil, South Africa, and Vietnam. And I shouldn't say we chose these countries, but rather these countries expressed interest in developing a tool like this and in trying to make the case for research using an evidence base. The technical advisory group was formed last March and comprised of national TB program representatives, other country-level stakeholders, policymakers at the global level, TB disease modelers, health economists, and epidemiologists. We developed a consensus agreement on approach to ensure really that in-country global stakeholders are both equally engaged in the process and to provide consultation on all elements of protocol development. The key that everyone agreed on coming out of the TAG meeting was that this really needed to focus on the country, and I think it has. There are 5 ways that we've tried to center the protocol to really focus on country-level needs. And the first is asking the countries to do a little bit of legwork on identifying policy questions first that are most relevant to the NTP. Afranio described some in his previous talk related to, for example, social protection in Brazil, and you'll hear more about that in a moment. Then to formulate their own research questions based on those policy needs, to then identify data sources that might be useful in addressing those questions, to build local capacity for doing the analysis, and then to use the results or develop a framework for using the results in order to prioritize research going forward. The objectives of the protocol that was agreed upon at the TAG meeting and which frames the work is first to collect and utilize data based on an initial situational analysis. And the key really here was to estimate the burden of TB, not just at a national level, but in specific subpopulations, and to consider how heterogeneity of those populations might impact investment in research, investment in interventions, and how impact will be defined. The second part of the protocol development was then to develop conceptual frameworks and mathematical models for understanding the impact of risk reduction in those key subpopulations. The third is then to use the results of these analyses to guide NTPs to areas of high impact potentially of research at both the population and subpopulation level. And finally, this would then develop a targeted TB and research investment case aimed really at providing a tool for local stakeholders and NTPs for advocacy, for furthering research in their national strategic plan. One key thing that came out of this work is that the way we consider data at the local level is really much more broad than just simple surveillance data. So it incorporates data from non-health related sources, ministries of social development, for example, ministries of education, surveys, data on other comorbid conditions not typically associated with TB, partnerships with NGOs, data from research programs, as in Vietnam, where there's quite a bit of research, for example, on contact investigation. Unfortunately, our Vietnamese colleagues could not come to describe some of that work, but they have a very strong partnership with the research community and a way for engaging with those data as well. So I'll just briefly go over how some of this process has worked in the 3 Pathfinder countries that are implementing this approach. In Brazil, we've come up together with a policy question to assess how do we address poverty as a key risk factor of TB. So this is the policy question. The research questions then derived are, for example, is poverty a significant TB risk factor, and if so, to what extent, and in what populations? Do poverty reduction interventions, such as Bolsa Familia, which you'll hear more about, have an impact on TB outcomes, and by what mechanism? And in this end, conceptual frameworks have been developed, and you'll hear more about some of the modeling in the next talk. In Vietnam, the policy question that was agreed upon was how should we better target our contact investigations for maximum impact with limited resources? And so research questions that were derived are specific subgroups of contacts at higher risk for active disease or LTBI than others. And this is really an exercise in better understanding local epidemics using relatively straightforward epidemiologic methods, but to do so in a somewhat novel way to inform a research agenda. And finally, in South Africa, the policy questions that Professor Churchyard will be talking about are how can we really target active case finding to yield maximum number of TB cases? And the research question was which risk groups and vulnerable populations have the highest risk? And in particular, what's the impact of active case finding in informal settlements where data is relatively limited? And the methods here included systematic reviews, conceptual framework generation, and deterministic compartmental models. And so how do we prioritize research based on the results of this? Well, I think it depends on the questions, and other speakers have addressed this as well. But to understand the local epidemic, the who and the where, we're really trying to confront more epidemiology research. To apply global level evidence to local settings is really the how that's really answered by implementation research. To use local evidence to then inform global level policy making is much more in keeping with clinical research. And then to understand the basic mechanisms of disease is important in the local context as well, and where it's available, basic science research is critical. I think that's my time. Finally, the impact that we hope to get from this is to inform the development of the National TB Research Plan and to develop some innovative tools for doing estimation of impact of research investment in various contexts. Our next steps will include developing those research projects using clinical implementation, basic science approaches where applicable. And finally, I'd like to thank all of those who worked on these projects, and in particular, all of the technical advisory group and the country teams who have dedicated a lot of time and effort to this, as well as the Gates Foundation for their support.
Great, thank you. Very nice. Now the Professor Ethel Maciel. Professor Maciel is an epidemiologist from the University Federal of Espírito Santo. Also is the Vice Chancellor of the university. And he coordinated the epidemiology area of the Brazilian Network of Research on TB. Okay.
Thank you very much for the opportunity to be here to discuss in a practical way how Rede TB is work with NTP in Brazil, and to show some results of this collaboration. So I have no conflict of interest. So the objective of my talk today is I'll talk a little bit of the state of art in research for tuberculosis in socioeconomic status, describe a background of research on national TB database. I think we all know that we are very proud of our tuberculosis system in Brazil, and the gaps in current approach for decision making. So poverty in Brazil continues to be a very serious problem. 10% of population lives with less than 1/4 minimum wage. This match with the cutoff point for entry in the federal program. Approximately 10% of population qualifies for Bolsa Familia, which is the largest conditional cash transfer program in the world. We have right now 40 million people receiving these benefits. So Brazil is a very big country, and we have a lot of high heterogeneity inside country. So this is a little bit of 11 years time series in Brazil, and we have like almost 1 million TB patients in the database. So by the National TB program, it's a very huge number to work with them. So we have a very descriptive numbers to show you, like in this 1 million, 65% are male, 74 between 15, 34 years old. Smear microscopy is not performing 23% of this patient, and we have a very problem with culture done in Brazil, like 77% are not doing. It's before the gene expert in Brazil is doing in Brazil. And the cure is very low, 79, and default was 14%, and death comprised 7% in Brazil. So our research question, and we start, is how can social protection data on TB patient inform better or more targeted intervention? So the Sinan is our national system, is a mandatory, tuberculosis is a mandatory notification in Brazil. So this system is a very good proxy of incidence in Brazil, as all the diagnosis and treatment in Brazil are made by public health sector. So you cannot buy medication in private sector, and you cannot go, if you go to the private sector to see the physician, we are referred to the public health sector. So this is a very controlled program in Brazil. And this system contains a lot of variables: risk factor, lab results, clinical presentation of the disease, and treatment outcomes, another. And first of all, as a research, you have to think in a system that was developed for operational part to be fit in the research question and what we can make for do this. So first of all, we did a theoretical model to understand how tuberculosis in Brazil are what the determinants. So we divide this in 3 axes. One is more individual vulnerability, all the variables. Other is more programmatic or institutional, and the other is more social. The problem is that Sinan, there is no, for example, BMI, there is no information about socioeconomic status. We have some proxies, some proxy variables like educational and we put in Sinan color of skin instead of ethnicity. So we have this limitation. So we did a preliminary study with this Sinan to see what's the main the factor association with completing TB treatment in Brazil. So we identify some variables related to this, like being older in age, self-identify as indigenous or Asian ethnicity, having participated or in complete higher education beyond high school, not living in a rural area, being institutionalized in a prison. It's strange, but Brazil is after a very strong international, I can say, international intervention in Brazil. We have a very good program in prison for tuberculosis in Brazil, and DOT are very good doing in the prison. So this is being institutionalized in a prison, have diabetes and have extrapulmonary tuberculosis is very related with DOT, and diabetes and extrapulmonary TB are in high education patients in Brazil. So this is because we have this result, and being assigned to DOT. So beside that, we developed some models, and we came out with these 2 models to work with the Sinan. We are very interested to understand how the same group of the patient has different outcome. What determines this? So we look all this patient, HIV, prisoner, renal chronic patient, and diabetes, to see what determines different outcome in this patient. And we published this data, and we developed this another model with 5 hierarchical level to compare different groups, diabetes, non-diabetes, HIV, and no-HIV in this database. So in 2015, the NTP introduced a new variable on Sinan TB. This new variable tells us the cash transfer beneficiary and we try. We have this database like less than 1 month for this conference, so we are showing to you a very preliminary data. This study, we try to divide this into groups, the cash transfer subject and non-cash transfer subject. We exclude from the analysis the missing data I show to you, and São Paulo State, because São Paulo State has a different information system, and they don't have this variable in 2015. So this is 2015 notification in Sinan. So we have around 85 patient notification. São Paulo is a very important state notification, but we don't have this information. And we come out with 28 patients that receive the benefits and 39,053 that not receive the Bolsa Família, the non-including Bolsa Família program. The problem, we have some analytical analysis on this data, but the problem is that we have some bias because the people that are included in this, they are not receiving the Bolsa Família program. We cannot divide here, as we don't have socioeconomic status in the minimum wage or another thing. We cannot say if they are allowed to receive the Bolsa Família. So we decide only to show you the results, the profile of the descriptive analysis, this 380 to 800 patient. So this only to show this patient, the cash transfer beneficiary in tuberculosis subject in Brazil. So as you can see, the most part are between 18 and 64 years old. They are more black or mixed color in Brazil. They are more, it's like a little bit more male than female. They are less than 80 years of schooling. They live in a urban area, and the most part are in the northeast of Brazil. It's very similar from people that not receiving Bolsa Família. HIV are not a big problem in Brazil. Alcohol is 16%, and diabetes about 9%. Mental disorder it's become a huge problem in Brazil right now in TB patient. And what caught my attention is we have the rate for die for tuberculosis and die for other disease. It's much more high than in the other TB patients. So we have to look more about this. Probably we have another comorbidities that are related with this and that can be important to this. So the conclusion is, even with socioeconomic status as a risk factor, there is a significant heterogeneity in relationship to tuberculosis. NTP policies should consider heterogeneity in each local context and acknowledge this difference and provide guidance in implementation such policy and TB control activities. This is very important for Pillar 3, and we in Rede TB, we are working in a very close contact with NTP. Right now, we have in each research, we have a focal point in NTP that work with us. So these are very important to all the results because we can discuss together and we can see what's the mistake or what's the problem and what needs to be in the next step. So we believe that research and the Pillar 3, it's very important to change in the field all the things that NTP are doing, especially in Brazil and probably and of course, in other parts of the world. So this is, I would like to thank you, acknowledgement for Christian, Priya, Afrânio, the father of Rede TB, and thank you very much.
Now we have our last speaker, then you have some time to question. It's Professor Gavin Churchyard from, he is a group CEO of the Auron Institute, a non-profit public benefits organization that aims to improve the health of poor communities through TB and HIV research. She is also a co-chair of the South African TB think tank that advises the National Department of Health on TB policy.
Thank you very much for inviting me to give this presentation. So I'll share what our progress has been and our experience of doing this investment case for TB research. Just to declare that we have a grant from the Bill and Melinda Gates Foundation for doing modeling for policy, which complements this work. So I'll give you a brief overview of the South African epidemic, tell you briefly about the National TB think tank, the investment case for research, the investment case for TB research looking at key populations and then specifically on informal settlements, and then just conclude with the NTP strategic plan that we're currently in the process of developing. So South Africa is one of the high-burden countries. We have noticed a decline in TB incidence over the past few years, but you'll notice that there is still a large gap between the estimated incidence and the case notification rate, suggesting that there are still many missed cases of TB in our populations. So the slide has already been shown as part of the Pillar 3 activities. We worked with a group to do the TB targets modeling, which included South Africa, China, and India. And the aims of this project was to assess the NTB targets in these three countries and the impact of existing or near-existing interventions if scaled up to ambitious but feasible levels on TB incidence and mortality, and then to look at costs and cost effectiveness. So the interventions that we initially looked at was access to care by increasing access to high-quality TB services, improving the post-diagnostic TB care, and reducing the pre-treatment or the initial loss to follow-up and improving treatment success, active case finding in the general population, active case finding coupled with preventive therapy, and then continuous eyes and eyes of preventive therapy for people living with HIV, and then combinations of these interventions. So the first thing to note is that in what we modeled as part of this initial process, we did not include informal settlements. And what we did is we used a multi-model approach, and there were 8 models for South Africa, and we used country experts and then advocates to help set what these targets should be and what we thought the potential impact would be if we scaled up these interventions. You notice that the experts did not support at the time active case finding or active case finding linked with IPT, whereas the advocates did. For the advocate scenario, the active case finding, particularly if coupled with preventive therapy, would have the single largest impact. But ultimately, it's the combination of these interventions that's important for achieving population-level impact. So this was then utilized and adapted for the South African investment case for HIV and TB, and this was then converted from what we did with the targets to really focus it on the 390s that were initially proposed for HIV and then adapted for TB. And as part of the 390s for TB, it did include screening in high-risk populations. Not to go through this in any detail, but the top dashed green line is really the baseline scenario, and the bottom green line shows the potential impact if we scaled up both the 390s for HIV and the 390s for TB, suggesting that by using this combined approach, we could potentially have a large and durable impact on the TB epidemic in South Africa. So now moving on to the investment case for research. So, sorry, just before I do that, just to mention that the initial work was done under the auspices of the South African TB think tank, and that was under our working group 1, which was modernizing TB control, which included the modeling and cost effectiveness as part of that. And so that work was done there. So for the investment case study for TB in South Africa, our deliverables were to develop a situational analysis regarding one key risk factor and constructing a data inventory regarding that population, and then to develop a multi-intervention model or other analytic framework to include input parameters reflecting the key risk group. So the National Strategic Plan in South Africa that is just ending did include a focus on key populations, but these key populations were really the peri-mine and labour sending communities in South Africa, in the mines themselves, and in prisons. It didn't really include the other informal settlements. These are the key populations that we identified as part of that NSP, and as I've already mentioned, was really miners and prisoners. And then in these peri-mining communities, we had included informal settlements there. But clearly informal settlements are far more widespread than just around the mining communities. And so we did this situational analysis to look at which of these key populations were contributing the most to the national TB epidemic. And so what we've shown here is we've plotted out for the different risk groups what the overall contribution to the national TB epidemic is. And not unexpectedly, of course, HIV is a major contributor, contributing about a third of the cases. But then informal settlements stand out very strongly as another group which, although we had suspected, we did not really appreciate just how much they were contributing to the national epidemic. And so just to show you these figures in a bit more detail, so in South Africa, we have a population of 54 million. We estimate that there are over 3 million people living in informal settlements, and that this group contributes to almost 150,000 TB cases in South Africa, so again, about a third. So really a previously unrecognized group contributing to the epidemic that we had not focused or targeted for interventions. And so now really focusing on these informal settlements, and starting first of all with the definition for informal settlements, and we've got two, and that these are really unplanned settlements on land which has not been surveyed or proclaimed as residential, consisting mainly of informal dwellings. And the Statistics South Africa define it as a makeshift structure not approved by local authorities. And so the key population, as I've said, is this informal settlement. They are large populations, predominantly of young people, and they really do have poor living conditions, and there's a high level of unemployment and poverty. So in South Africa, it is heterogeneous in terms of the burden or the size of these informal settlements within the different provinces, ranging from a very low 3% in the Western Cape, 1% in the Northern Cape, up to the highs of 23% in the Gauteng province and 27% within the KwaZulu province. So quite heterogeneous, but in at least two of these provinces, a very high proportion of the population are living in informal settlements. So just looking at the epidemiology of TB within the informal settlements, so there's 1.2 million households, a population, as I said, of over 3 million. The TB prevalence is estimated at 2.5 per 100, TB incidence of 3,500 per 100,000, and they also have a high burden of MDR TB. And that's in the studies that have been done in these informal settlements, very high yield of TB through the screening programs. And a large proportion, of course, are HIV positive. So in terms of this particular project, where are we? We've done the literature search and review. We've done this whole situational analysis and presented these findings. And as I'll show you in the next slide, we have incorporated this now into our policy and decision making. So the next stage is ongoing around still working on these epidemiological factors and creating the data inventory that can serve as a model for developing the large-scale data portals. And we are still planning the mathematical modeling or analytical framework to determine the intervention impact in this population through our working group 1, which is the modernizing TB control, and the modelers within that group will then be taking this forward. But how much has South Africa invested in informal settlements up to now? And this is from the Gates Foundation TB landscape or landscape mapping exercise that they took. And we're currently only spending about 3% of our spend within the NTP on informal settlements. And yet this group account for a third of all the TB. And so clearly we're going to need to try create more balance and target both funding and interventions to this group. And so although we haven't yet completed the modeling, this information has been really very important, feeding into the development of the National TB Program Strategic Plan for 2017 to 21, which will be folded into the National Strategic Plan for TB, HIV, and STIs. And as part of this, so this is still draft, we're in the process of finalizing this, but we're proposing 5 core NTP interventions, but one of them is active case finding among select populations, which now specifically includes informal settlements. So this information has already informed policy decision making. So in conclusion, South Africa, one, can serve as a model country for this investment case for TB research. The National TB Think Tank includes, it's a broad encompassing group, includes basic clinical and implementation researchers and provides this interface between researchers and the Department of Health. And the South African Medical Research Collaborating Centres provides a large TB-HIV research network, which also embodies the Report International networks under this group. The informal settlements contribute to the national TB burden, and clearly our control activities should be targeted to these informal settlements. And just to lastly acknowledge Salome Charalambis, who is sitting in the audience and who's played a leadership role in doing this work, and Lucy Chamoy, who has been hard at work preparing all this data that I've shared with you. So just to acknowledge them and thank them very much. Thank you.
So thank you very much, Gavin. So we have time for questions now. We have had first 3 presenters who told us about how to establish or how they have established national research plans at country level, with example of Ethiopia and Brazil. And then we had 3 other presenters who looked at a more sophisticated way to try and look at specific data and how data from specific population can derive the research agenda and then influence the prioritization of research at country level. So the floor is open for discussion. Yes, Edzo.
I'm Ezio Tavora from the TB Researchers Network. Well, thank you for the presentations. I thank you for your presentation about South Africa, because when you presented an assessment with the activists and how the communities affected see the implementation of is impacting the social the communities, I mean, this is where we want to reach. I mean, what I felt in the first 2 presentations of this second part is that there is a lack of 2 aspects. One is a more qualitative approach and a more patient-centered approach, because if we want to inform policies and if we want to influence policies, because that's the final objective of this initiative and to boost the pillar 3, we have to really listen carefully and be informed of how the services and research has been conducted so far, because we are far from being in a comfortable situation in terms of service delivery. And although we have made progress in Brazil, we are far from being in a comfortable and acceptable situation with the impact on death and impact of morbidity is far from being, so we cannot say that we are happy with the situation in Brazil at all. And in prisons, the same. I mean, some prisons may be having a good DOTS service. Actually, DOTS is easier there because people are in prison. So that's the easy way to deliver DOTS, so to force them to swallow the pills. But the point is how it's not all over the country. So it's in some prisons. And Brazil has the 4th largest imprisoned population in the planet. So it's a big task. So I think we have always to choose with whom we work and with whom we do research. I was just coming from another session where implementers and small industries were complaining that they cannot approach big universities or do research, implementation research, or create evidence on their technologies. And then I asked, why don't you approach universities in the developing world? They said, when we do that, we come back home and then people say, like, why did you collect evidence in these universities or in this place which don't have international impact? So that's the whole point with whom we work and how we are seen throughout the world. But the most important thing is that the countries are providing information and policies to the countries. That's what matters. What South Africa is doing for South Africa, what Brazil is doing for Brazil, and each country is doing for them. I mean, that's the most important aspect. But we have to have a more real and not only rhetoric, patient-centered approach.
Okay, thank you very much, Endo. And then that's very clear, and that's exactly what this we are all speaking about, and that's exactly why we said very clearly, and the examples was given, excuse me, that civil society is part of the network on TB research from the start, and I'm sure Franjo or Estelle would like to comment, but that's exactly what happens in Brazil in order to address this issue about qualitative aspects of research. So thank you very much. There was another question. Yes, Yared, please go ahead.
Okay, thank you very much for the excellent presentations. I have a couple of remarks. My name is Yared from USAID, Ethiopia. The third presenter, I think 3 countries are included, excluding Ethiopia, and trying to work with WHO, why Ethiopia is excluded, and just an answer for that. But I would like to make a broader kind of comment on the experience of Ethiopia. I think there's a need for really huge resource, not even huge maybe once the system is established, but at least a seed resource to establish a system of operational capacity building. I think some of the initial trainings and technical assistance could be a bit expensive until the country becomes really self-reliant and builds the institutions. So maybe as part of the roadmap that WHO is kind of developing, I think the financing has to be properly included, how to finance operational research capacity building. I think that's probably there, but I didn't hear it. And there are alternatives. I think the Global Fund is a very good potential resource. I think if countries accept operational research as part of their work, include it into the national strategic plan, then they should budget for it. So just wanted to highlight that. So the resource requirements, especially to sustain the Secretariat, to ensure annual conferences are held, all require resources. Thank you.
Priya, as you're going to comment, it's interesting also that you commented, because not so many countries has adopted yet, as you show in the map. But what do you think about that? That more countries will adopt that? Will be in the movement, or how is going the back of the process?
Thank you for your comments. I think it's an excellent point. The first three, this investment case approach only started this past year. And so it's very new, as is, of course, our work in Pillar 3. And these countries were not selected by us. They were countries that have an interest in modeling, mathematical modeling, and in doing this type of analysis. And so this was chosen as a proof of concept kind of round. But of course, if there are other countries now who are involved in the research pillar, developing national research strategies, who are interested in this approach based on these presentations, we would be more than happy to discuss more how to facilitate some of that work and adoption of some similar methods. So I think this by no means was closed to other countries. It was countries approaching us with an interest in looking at some of these methods, using those tools, and having some initial capacity in that area.
There were 4 countries where experience was shared and used for developing the roadmap, but 3 of them are included. That's why I was asking.
Yeah, and there is another point, Yared, and that which is important to consider, is that what we're proposing is a global action framework for TB research. It's global, yeah? And the toolkit that has been launched 2 days ago is a system, a step-by-step system that we propose to countries so that they can develop their own national TB research agenda. Part of this development of a national TB research plan includes the fact of looking for funding. And we make the case that there is a need of funding research at national level very clearly, and there are a variety of funders. There are external funders, but there are also national funders. So we make the case, and we start with the BRICS, that the country themselves should contribute to the funding of research nationally. And this is being increasing a question and increasing demand, which is being put forward. And we can hear more and more, in fact, that the BRICS wants to invest and to involve higher and more largely into the funding of TB research. That's one. The second is that we have started and initiated discussions about what you perfectly mentioned about the Global Fund, and there is a need to make sure that among the Global Fund support to countries, there is the possibility to do this research and do implementation research, which is really serving directly the program. And there is open door also for all other fundings from various NGOs and contributing, and bilateral and multilateral collaboration. So you know all of them. I mean, you present USAID in Ethiopia, and USAID contribute to that through many schemes like Challenge TB, etc. So the case is there that there should be an increased investment on research at the national level. And we are really working on all of that. So thank you very much. There is another question?
Yeah, I just had a comment, if that's okay.
Please.
I really appreciate the presentations, and I'm glad to see the work, Brazilian work on the poverty aspect, how they have brought in. I was just wondering if you considered also the indicators on nutrition, and taking into the context of India, it's one of the key factors for us. So I think I would like to take some more notes from you and see how we can do it in India. Just a small update on India, about the research network that has been presented here. So recently, India has also come up with a research network. We call it as the India TB Research Consortium. It was inaugurated in August 2016. It is led by the government agency, Indian Council for Medical Research. So we have 4 different working groups that have been identified, and they have identified the national experts. And earlier this month, we had the first working group meeting of this consortium, and we are really encouraged to see how the country's research can contribute into TB work, and these case studies are really encouraging for us. As a part of the union, we are supporting the consortium, as Sir has raised the issues on the funding, and I totally agree with Dr. Christian about how the funding has to come in. So part of it, like union is supporting through our Global Fund project, but there are ICMR, which is the lead. They are also identifying the various government agencies who can feed in, and we are collaborating with the different departments And later this month, we are going to have the international advisory meeting also. So I hope that next year, India would be able to present from the consortium some good outputs of this work. Thank you.
Thank you very much. Thank you. Really, it's, everybody's pleased to hear that, and of course, we'll be more than delighted to welcome Indian representative to this type of symposium next year. And I think India has to really be commended for establishing this Indian TB Research Consortium.
Well, there is now some time to more one question. Someone to, or a comment, yeah? You, Gabby? Oh. Etel. Okay.
So about the BMI, I would like to answer to you. Because on this national system, you don't have this information. But we have some information about clinical trials, and we are doing a cohort study looking cash transfer in Brazil. It's the sample size is 1,200 TB patients, so you have all this information. From the preliminary data, we have, this is not a big problem in Brazil, the BMI. In the clinical trials, the median BMI was 20. And in this cohort that we are in, we have 800 TB patients right now, it's 23. So 20.3, sorry. So this is not a big problem, but we don't have this information in the system. So just to make a point, I don't know, sorry, because English is not our first language, so it's make some mistake problems. And as you point out, and I want to be very clear about this, we are very proud about our system. We are not proud about our number, and this is very different. So I would like to make this point. Thank you.
Okay, thank you. I think it was a great meeting, great symposium, and yeah, I think for me, I think one important point to stress is that this experience that WHO is leading in tuberculosis go beyond tuberculosis. I think that there are huge impact on research and public health in general. I think the success of implementation of this program, would have a huge impact on public health in general, and us as researchers in developing countries, can articulate all the process to produce knowledge and the use of this knowledge in terms of control and improve the health of our population. Then I think this is really one thing that everyone is because it goes beyond TB. I think this is an important point. That this needs to be very careful. And very well documented, all this process, because this experience is really very, very much important for, I think, the humankind in general,
And Mauricio, you've been leading absolutely great work in Brazil about looking at the impact of Bolsa Familia, which again is unique and the largest cash transfer system in the world that has been established 15 years ago, I think, or more than that. So you've been leading studies on the impact of Bolsa Familia in childhood health and childhood mortality. So what would be your advice? I mean, you have done this type of work looking at the impact of a large system on the health of a large population. So what would you be your advice in what we are trying to do for
I think my main advice is that the poverty-related cause of disease is so important that it need to be inserted in the healthy programs. And, you can't think in control disease like TB or improve child health without thinking on improving the overall condition of this population. The health intervention are important, but all the social protection intervention are also important. Brazil, for example, has this is a good example. Yeah, Brazil before the implementation of the large social protection program, Brazil have a child mortality that was an outsider. Brazil have compared with the other countries of the world, Brazil had a level of mortality that was above the level of the GDP of the country. And after the implementation of the program, very quickly the infant mortality decelerated, yeah, and come, yeah. Now Brazil is in the expected level, yeah. Okay. Then I think you can dissociate it, all these efforts to understand poverty and to understand the link among poverty, inequality, and the other major social topics, yeah, and the control of the poverty-related diseases like TB, leprosy, or child health in general, yeah. Yes.
Okay, very good. So if there is no other question, I think we are going to close that right on time. So thank you very much for your being present and listening to all the presenters. The door is open really to do more work with the countries, and we are here really to help and assist as much as we can. So if there is any interest from any country to be working on implementing or developing or strengthening a national research strategy or national research plan, then of course we are absolutely present and happy to help. Thank you very much, and have a good continuation of conference.